To Dr. Manish Chakravarti.
Thank you, sir.
Good morning, sir. I thank the organizers for arranging such a lovely conference in amidst just post-COVID period. And today's topic is also again the corona, which has not left us. Creepy corona and the coronaries. I would rather put it as corona creeping into the coronaries. So let us see. The coronavirus, as we know, the SARS-CoV virus is a novel virus which started with like a virus which affects the respiratory system along with fever and the body aches. But then we have seen its potential, which affects, has left no system unturned. It has the potential to affect the cardiovascular, the gastrointestinal, and the CNS. And the overall mortality and the morbidity depends on the associated complications. So the mechanisms, without going into much details, we have seen that the virus can cause direct myocardial injury in inducing the cardiomyocytes, which can cause damage of the myocardium and then cause LV dysfunction and failure. Indirectly, then we have seen that if there is an overwhelming immune inflammatory response, which is similar to the Kawasaki disease, and then also forming a cytokine storm and cascade of symptoms, which we call as MIAC. The other mechanism may be the severe hypoxia from the acute respiratory damage, which also caused increased myocardial oxygen demand and causing myocardial injury. These are the changes which we have seen more in the adult population. The mechanism to go into more advanced research, you have seen that the genetic concept in the Kawasaki disease, where there are variations in the FcGR2 Fc gamma receptor, has also been found with the SARS-CoV-2 antibodies, and they also activate the neutrophils in the macrophage, which can be responsible for the cytokine storm and the MAS. So it's like the Kawasaki only that there might be no coronary artery changes. There can be transient dilatation. Usually this dilatation and the prominence of the coronary artery walls, which is noticed on echocardiography, which dissolves in 4 to 6 weeks. There can be necrotizing arteritis if this has not resolved, leading to the dilatation of the coronary wall, causing aneurysms. There can be further progression and possible interaction with the atherosclerotic risk factors, and then in the late changes, we can have the irregular wall of the coronaries complications with the calcification and thrombus formation. So COVID in the acute state where there is a positive infection can cause shock, cardiac failure, LV dysfunction, and very less we have seen the coronary involvement in the children, only in a very few case reports. But after the COVID infection, with the COVID antibody being positive, within 2 to 6 weeks, it is Kawasaki disease like illness along with the multisystemic expression in the form of MIAC, which is more troublesome for us. Adults, we have seen, I have described that there can be more incidence of acute coronary syndromes, and in patients who are also already having impaired cardiovascular functional reserve, and also the comorbidities. While in children, the incidence is only 1 to 2% comparison with the adults, where they are clinically symptomatic during the active infection. Mostly they have the mild or the low symptoms, but the cardiac involvement is very common in the MIAC group. The shock, arrhythmias, infusion, and the coronary artery dilatation are the 4 most common cardiovascular abnormalities. All the guidelines which we have seen during our last 2 years with the state-wise investigation in patients with MIAC mentioned about the echocardiography, early echocardiography, and where there was mention of coronary involvement. So the maximum, largest study which we found was the European study with 286 patients, where they have found that the 34 increase in the symptoms like Kawasaki disease. But this happened unlike Kawasaki in the older children more than 6 years to the adolescent group, and the markers were different in this group. The coronary artery involvement was seen in around 24% of cases, but there were no significant coronary caliber during the hospital stay. There are other studies by Java where they have screened 17 patients and 6 patients have found dilatation in 17% of them, including dilatation of the left main and the dilatation of the right coronary artery, but there were no incidents of coronary aneurysm. There are other case reports of 35 children febrile, and in a larger study of 58 where incidents were around up to 26. In fact, Indian study of 23 patients also had only 6, that is 26% of coronary artery dilatation. So there are other further studies I'll not go into. All of them had SARS-CoV antibody positive, and the coronary involvement was around 6 to 26. So like Kawasaki, here also we had seen that there can be the significant dilatation or aneurysms in some of them, where the initial baseline echocardiogram in the first 10 days of illness showed some change in the coronary arteries. The largest proportion of patients will have dilatation only, characterized by the luminal measurements outside the range, but their maximum Z score within 2.5. And these dilatations resolves within 4 to 8 weeks. But most importantly, which we all agree, that we have seen the echo-bright coronaries, which means the coronary is very easy to detect in our echocardiography, which usually is not so, as we see in this picture, and even if they are not dilated in size. The guidelines for incomplete Kawasaki mentioned about the perivascular brightness of the coronary arteries and the lack of tapering other than the increased Z score of the left and the right coronary artery. And here also, I think we have to give stress on this tapering of vessel and increased echogenicity before we can see some dilatation, because the aneurysms, that incidents are less, so that we can early detect them by echocardiography and start their treatment. Quantitative measurement of the echogenicity is also been done in other centers, but in India we hardly have any data for that. The measurements according to the Japanese were the inner to inner edge measurements of the diameter. There can be focal dilatation if the sharp angle of the branching points become blunt, and dilatations and aneurysms should be considered. As we see in this picture, we can see the loss of tapering and there is some focal dilatation, and the angle is blunt and not acute. So these are the factors where we should suspect about coronary involvement. Aneurysms, there can be, Japanese, they had defined as less than 4, more than 4, and the measuring of internal diameter 1.5 times that of the adjacent segment. But nowadays we are everywhere confined to the Z scores, which is much more scientific, and these Z scores should be calculated, measured and monitored periodically. So the Z scores, no involvement will be a Z score less than 2. The dilatation will be 2 to 2.5. Small is 2 to 0.5 to 5. Medium between 10 and less than 10, and more is more large or giant aneurysm more than 10 millimeter, more than 10 Z score. So how to measure the coronaries we see here? Left coronary, we can see the proximal and the distal LAD. The proximal before the septal branch and the mid after the septal branch. We have to measure the internal diameters. We have to zoom in different measurements. The right coronary artery similarly again with the proximal and the mid. However, in echocardiography mostly we get to see the proximal segment only. So here there are some pictures where we see the coronary is not enlarged in size, but the walls are definitely thickened and the loss of tapering is there. Here we can see the same patient was not given importance, not given IVIG because of financial reasons, and then later on after 14 days developed dilatation of the coronary artery. So here we see the other dilatations like a huge aneurysmal dilatation of the coronary artery, and we have to see the branching of the coronary artery. If the branches are also enlarged as much as the main coronary artery, so we should be aware of the process going on. Here there are different types of dilatation. Here again we see there's loss of tapering, and query where it divides, there might be some thrombus, so we have to go to some further imaging. The coronaries can be again saccular aneurysms like this, where there is dilatations. There can be diffuse swelling or diffuse dilatation. It can be seen in different views. If not one, we have to make an attempt to see the coronaries in different views, to see the dilatations. See, the walls are so prominent and they need further investigations. The soft markers of the cardiac involvement, there are different studies which have given shown that there might be no difference in echogenicity, but there are a study by Takahashi et al. Who have shown that all patients who later developed enlargement initially showed this echo brightness. So the quantitative assessment had come where the value of echogenicity was evaluated in decibel with the KeyLab software by Philips, and points of interest were measured in different segments, and it has been seen that it was significantly higher, the echogenicity in the areas where there were dilatation later on in the acute phase. And it also can be measured, the quantitative, by the calibrated integrated backscatter, also by a QLab software. And it is on, there is seen that if the values are too high, the response to IVIG can also be, we can have an idea of the responders of IVIG from these values. So really see the dilated coronaries, we should put color and see whether the color flow is okay or not. There is any filling defect, to look for the thrombus, which are more likely here, like we see where the flow is not maintained. So we can put the velocities, and the stenosis and p-stenosis velocity difference can give us an idea of the thrombus, so that we can start our treatment. The practical tips, I want to mention that we have to measure the body surface area accurately, because a little difference in the surface area can make a larger difference in the Z-scores, which can change the patient's risk category. And for irritable patients and toddlers, it is always better to sedate them to look for coronaries. Additional use, if the Z-scores are not available, you have to measure the surrounding segments, and more than 1.5 times should give us some clue that we have to be careful about these patients. This was the study of European, where we seen that the coronaries were not much dilated. There are no much aneurysms, and within hospital stay, we have not found any acute changes in the size. So when we don't see the coronaries beyond the proximal part, like here, we have to go for other modalities like the CT angios, where we beautifully see the dilatations of the coronaries of the right and left, and they can give
Dr.
us
Manisha, sorry, we have to wind up here.
So of the coronaries. So COVID, with CHD also, the COVID can be more serious. So we have to be careful about that. And in the management of protocol also, we have seen that the management with IVIG and steroids, more like Kawasaki disease. So we have to know about the management properly. So to conclude, it is COVID is creepy, scary, and now it is becoming an endemic disease. So that gives us more responsibility to have a vigilant approach, and testing is a main stay of identifying the infection. Still, most children will remain asymptomatic. MISC involvement have better resolution, like Kawasaki and coronary involvement have better resolution, but lot of research is still needed, and they should be followed yearly till we know better. The research about the pathogenesis will help us in our treatment protocols. Thank you. I know we will overcome one day.
Thank you.